medical doctor from the Netherlands. I'm a pediatric resident at the Wilhelmina Children's Hospital. And I finished my PhD on the burden of respiratory syncytial virus and novel preventive interventions against this virus. And as a clinical researcher, this talk will mostly focus on clinical implications and real-world effectiveness of monoclonal antibodies for RSV prevention. These are my disclosures. So RSV is a hot topic at this moment. You've probably all seen some of these headlines passing by in recent months and years. It's exciting to work in the field of RSV at this point in time because we now have, finally, after many years of development, infant immunizations available as well as vaccines for older adults. And being in the States, I just saw this CDC headline on my timeline this week. CDC reported that RSV hospitalizations have really plummeted since the introduction of RSV immunizations for infants. And I'll go a bit into more detail about that. First, some background, and I deliberately chose this picture of a child in a low resource setting because I think these are the children for the foremost that we should be talking about RSV prevention, and it will become more clear later why. A bit about RSV. It's a single-stranded RNA virus with two major subtypes, the A and B type, circulating simultaneously with comparable disease severity. RSV usually causes upper respiratory tract infectious symptoms. They can progress to lower tract respiratory symptoms like shortness of breath, wheezing, and this can be life-threatening. I think most clinicians know RSV from causing bronchiolitis in infants. That's the most well-known manifestation. Risk factors are, of course, major comorbidity, but I think the most important risk factor is just young age. There's no specific treatment, no antiviral treatment available, only supportive care, supplemental oxygen, mechanical ventilation. And RSV usually occurs in seasonal patterns. In temperate climates, such as in Europe, it's usually winter months. I think for a large part of the US as well. But more in more tropical climates, it can be a more year-round pattern. And excitingly, it's now a vaccine monoclonal preventable disease. RSV is very, very common. I think everyone in this room has been infected with RSV at least once. We performed a major birth cohort study in healthy term-born infants in Europe, in 10,000 infants, followed them for the first year of life, and we found about a 2% hospitalization rate in healthy term-born infants. So that's a huge number of hospitalizations on a yearly basis. Most infants are younger than 3 months of age, and luckily mortality is very rare, but that's because we have access to high-quality care in high-income settings. And on a global scale, that picture is very, very different. RSV is the second leading cause of infant death worldwide. And nearly all deaths occur in low middle income settings because limited access to required care. My colleagues did a great job in characterizing the burden of RSV in LMIC settings. And on the right, you see depicted the age distribution of RSV hospitalizations in LMIC settings and also mortality. Mortality predominantly occurs in those younger than 3 months of age, especially those younger than 1 month of age. And that means that efforts should be focused on RSV prevention in those very shortly after birth. And I'm talking about infants all the time, but RSV causes reinfections all throughout life. And usually reinfections cause milder symptoms, but in high-risk populations, high-risk adult population, especially older and frail adults, it can still cause very severe lower respiratory tract disease, life-threatening disease. And there are vaccines being developed and market approved at this point for the older adult population as well. But we're not here to talk about vaccines. We're talking about monoclonal antibodies today. And RSV prevention has come a very long way. I think the major game changer on the journey to effective RSV prevention for infants is the discovery of the RSV pre-fusion and post-fusion F protein. F protein stands for fusion protein, and it's the glycoprotein on the viral surface that enables cell fusion, viral fusion with host cells. And about a decade ago, it was discovered that this protein has a metastable pre-fusion form, and that when you target the antigenic site on that pre-fusion form, that has way more neutralizing capacity. And traditionally, most interventions were first focused on that post-fusion form, which is the stable form. You can imagine if you target the pre-fusion form before fusion, that is way more effective in RSV prevention. And so that really led to a surge in vaccine candidates for RSV prevention. We now have mRNA vaccines. One is approved for older adults. We have live attenuated vaccines for toddlers coming up. We have a protein-based maternal RSV vaccine, which is also approved for older adults. And we have the monoclonal antibodies. For infants, we have palivizumab for quite some time, so now also nirsevimab and clesrovimab is awaiting approval now. And we have the maternal RSV pre-F vaccine to protect infants from RSV. Why only those monoclonals and that maternal vaccine? Well, as I just said before, we really need to protect infants just right after birth. And that's the point in time when the immune system is still immature, and that limits them from rendering effective immune response upon vaccination. So we have to rely on passive immunization, which is temporary protection, but you can at least protect during that period of time that is most critical. Generally, there's two approaches. Maternal vaccination, we know that from pertussis, from tetanus, from COVID, from flu. Mother is vaccinated during pregnancy, and the antibodies are transferred across the placenta, and then you have protection with your maternal antibodies after birth. But they do fade, of course. And there's some limitations. Antibody production may be suboptimal in immunocompromised mothers. And in case of preterm birth, the transfer may be suboptimal. And then you have the monoclonal antibodies, and I'll go a bit more into detail. So the first monoclonal antibody for RSV was palivizumab, and it has a relatively short half-life, about 20 days. It targets site 2 on the RSV-F protein, and it has been around for about 30 years now, and it's quite effective. But the major limitation is that it needs monthly injections because of that half-life. And that is, of course, very burdensome for infants and also very expensive. And its use has been limited to high-risk infants only, Down syndrome, congenital heart disease, pulmonary dysplasia, and only in high-income countries. And as I just said, that is not enough. So the journey continued, the search for effective RSV prevention in infants, for all infants. And so the second game changer was the development of extended half-life monoclonal antibodies for RSV. Due to a mutation applied in the FC region of the tail of the monoclonal antibody, they were able to extend half-life with about 3 to 4-fold compared to palivizumab. And that means that with one injection, you can protect for about 5 months, and that means you can cover a typical RSV season, so a typical winter season with one injection. And you can administer that seasonal at start of the season, or you could do it year-round, depending on seasonality in those countries. And so very recently, nirsevimab was market approved as first long-acting RSV monoclonal. It targets site 0 on that pre-fusion F, and it's approved in many regions in the world now for use in the first year of life, and for high-risk populations also in their second year of life. And in clinical trials, it showed really promising efficacy with about 75% reduction in medically attended RSV and RSV hospitalizations. And there was some fear about delaying your first RSV infection to the second year of life due to immunization, and that it would be more severe because you would have just delayed that severe infection. But in the follow-up of the trials, that was not observed. And actually, quite quickly, a lot of countries adopted nirsevimab in their immunization programs. This is a figure showing the world map in 2024. And in blue are the countries that have both the maternal vaccine and nirsevimab approved. Not all have really implemented it yet, but most do. And some have chosen just for approval of one of the two. And as you can see, many countries have approved nirsevimab, or it's available, but no LMICs in this list. and still not. Spain was one of the first countries to implement nirsevimab. It was approved in 2022, and they immediately implemented it in the 2023-24 winter. So we have 2 winters of data now from Spain, and very impressive. They saw an uptake of about 90%, which is very impressive for a new immunization in an immunization program. And below you see the results, and the upper 4 lines are RSV hospitalization incidence rates before implementation, and then that lower line is the first season, and the bars are the second season of implementation, and you see incredible drop in RSV hospitalizations. And after that, a lot of other high-income countries published some first real-world results, all high-income country data. And last week, this meta-analysis was published in Lancet, showing a real-world effectiveness of about 80% against RSV hospitalizations. And mind you, it's the number 1 cause for infant hospitalization in the high-income setting. So that's amazing. And now we also have clesrovimab expected soon. Again, due to a mutation in that FC region, there's extended half-life. This one targets a different site on the RSV protein. And at ID Week last year, the phase 3 clinical trial results were presented, showing high efficacy against mild, moderate, and severe RSV throughout 5 months of follow-up, so comparable to nirsevimab. It's under consideration by the FDA now for market approval, and the decision is expected on June 10th, so very soon. So we have 2 effective long-acting monoclonals now, or the second one hopefully quite soon, but there are some challenges ahead regarding implementation. And I think the most important one is global access. I just showed you these 2 world maps on different slides, but now put them next to each other, and the incidence is highest in the LMIC settings, and on the right you see that figure doesn't match. Because there's no prevention available there. And that all has to do with pricing. To give you an idea, it's not publicly available, the pricing in every country, but it's estimated about $300 to $400 a dose, which is of course not feasible for all infants in LMIC settings. And my colleagues have wrote this opinion piece in Lancet stating that nearly all deaths occur in that setting, and that we have to really make effort to get those products there. We wrote a review about this called The Road to Global Access, and I cannot go into too much detail, but we outlined the urgent steps that are necessary for both the maternal vaccine or the monoclonal or both. Some steps have been taken. WHO SAGE has recommended RSV prevention for all infants worldwide, and it led to WHO pre-qualification of the maternal vaccine. Not yet for nirsevimab, but hopefully soon. That is a prerequisite for Gavi support, which will be necessary, although the pricing is way out of reach at this point. I think, well, Gavi is facing challenging times, so that's unsure for now, and I think as a research community, what we can do is raise awareness of this vaccination gap, and raise some public pressure to address this. Second challenge is maybe going to be public acceptance. We are all aware of, especially since COVID, a decline in confidence in vaccines in many regions in the world. Up on top of that, RSV awareness, the burden of RSV is not well known by many. And I think it's important to realize that this map will be the first map that will be used for infant routine immunization. And a lot of healthcare professionals in the public domain in pediatrics do not have that much knowledge about MABs. Talking to my colleagues, for example, parents of young children have virtually no knowledge of MABs, so that might raise hesitancy. But promising until now, the uptake of nirsevimab in those countries that have implemented it has been quite promising, actually. There is an important role, I think, for healthcare communication, education. This is a tool that we've developed in the UMCU, just a fun tool to mention. We developed an RSV AI chatbot based on a curated evidence-based knowledge base, and it's aimed to answer questions about RSV for the general public, for young parents, so that they can ask about maternal vaccination or the monoclonal, or if you have the choice, like in the US, which one should you choose, side effects, well, and so on. So I'd like to invite you to try it, and if you have any feedback, please let me know. If you Google RSV chatbot, you will find it. Then finally, there is a fear, this is not my expertise, but I'll like to touch upon it. There's fear that the widespread implementation of MAPs will put some selective pressure on resistant strains, or that they will emerge. Reassuringly, in the genotyping studies in seasons before implementation have shown that the sites, the binding sites for nirsevimab, for palivizumab, for clesrovimab, are actually very well conserved. That was before implementation of MAPs. In the clinical trials of nirsevimab, breakthrough variants were very rare, and also there's a study from France, also genotyping breakthrough infections after real-world implementation, and that was mostly due to suboptimal dosing and not so much because of resistant strains. I think it does highlight the need for ongoing surveillance and genotyping to monitor the potential emergence of resistant strains. And I think it also points out that there is a use case for multiple MAPs targeting different sites used side by side, so that we will have nirsevimab and clesrovimab and maybe other MAPs in the future in case resistance would emerge. To wrap it up, I hope you will take home that RSV causes a major global health burden, especially in infants. That there is prevention possible but not available everywhere. We have a maternal RSV vaccine, and there are now extended half-life monoclonals, which can protect with one single injection for the most critical months of life. And these work in the real-world setting, so that's very promising. But there are some challenges. We need a collaborative effort to ensure global access. We need effective health communication, realizing that nirsevimab is that first MAP for routine infant immunization worldwide. And I think we need ongoing RSV surveillance, including genotyping, to monitor potential resistance. With that, I'd like to end. Thank you all for your attention. I'd like to thank my colleagues, the group of Louis Bond, and please try that RSV chatbot, and I'm open to any questions later on. Thank you.